So let's talk about treatment of the relapsed or refractory HCC. What are our options for second-line treatment?
So going to the point of advances in systemic therapy for HCC is the fact that now there's an approved second-line agent for patients with advanced hepatocellular carcinoma. And that agent is called regorafenib. And regorafenib is very structurally similar to sorafenib with important differences. And it was looked at in what's called the RESOURCE trial, which was a randomized phase 3 study in a 2-to-1 randomization between regorafenib and placebo. And what it showed is that in the second-line setting, there was an improvement in overall survival from 7.8 to 10.6 months. The advances in hepatocellular carcinoma systemically have also translated not just from the frontline setting, but also to the second-line setting. And there's an agent called regorafenib that was shown in the RESOURCE trial to improve overall survival in the second-line setting. This was a large randomized study, phase 3, that randomized patients in a 2-to-1 fashion to regorafenib or placebo. And what it showed is that of these 573 randomized patients, there was an improvement in overall survival from 7.8 to 10.6 months. The important thing to remember about this study is that patients had to have progressed on sorafenib. What often happens in second-line studies and subsequent line therapy studies is that patients are allowed to accrue with intolerance. But this was a very stringent criteria for progression, so this was a true population of people that progressed after frontline therapy. In addition to the data from the RESOURCE trial, there's some other recent data using other agents that also have shown an improvement in overall survival, one of which is called cabozantinib in the Celestial trial, as well as immune therapy agents, immune checkpoint inhibitors, such as nivolumab, which was recently given accelerated approval for at least a second-line setting of advanced HCC, as well as some other agents that we'll speak about later.
What factors help you decide between going to another tyrosine kinase inhibitor versus immunotherapy?
Up until recently, regorafenib was the only second-line agent approved, and so there was not really a difficult decision process to undertake. Now with the recent accelerated approval of nivolumab, there's really a decision point that needs to be considered. And I think it's important to take into account that regorafenib was a large phase 3 study. Nivolumab was approved on a phase 1/2 trial, a smaller number of patients, and it was not a randomized study. And so I think that those are important factors to consider. But beyond that, you also always have to look at the patient characteristics and comorbidities. And one of the significant toxicities or potential toxicities with regorafenib is liver dysfunction. And that's an important factor, especially when somebody has underlying likely cirrhosis and primary liver cancer. And so that might be an important decision point to favor immune therapy. It's also important to keep in mind that in the nivolumab trial, PD-L1 was not a predictive factor of benefit as it has been in other studies. However, microsatellite instability may still be predictive, as may be additional predictive biomarkers that are identified over time. So I think that when you decide one versus the other, a lot of it depends on comorbidities and the strength of prior data. And the final point is toxicity profile of the agents. Nivolumab or checkpoint inhibitors in general, are typically very well tolerated. The risk for autoimmunity is real, but low. And regorafenib has some important toxicities to be aware of. Most importantly is the fatigue that can happen, because it could be sometimes profound. Also, there's unique cutaneous toxicities, hand-foot skin reactions that are distinct from other oral agents that we think of. And so we need to monitor liver function. People can have loose stool. And so all these factors come into play.